Thank you for joining us today at the June 26, 2023 Ask an Expert session. We have two great speakers with us today. The topic for today is secondary stroke prevention, what you need to know, understand the terms used by medical professionals when they talk about stroke prevention, understand risk factors for stroke, what are they and how do you manage them, understand how lifestyle contributes to stroke risk and what you can do to reduce stroke, identify the signs of stroke and what to do if you think you or someone you know is having a stroke. Guest speaker today, Alison DeWitt. She's an RN, BSN. Mal is a clinical nurse specialist with Stroke Services BC. She's a registered nurse with 10 years of experience in the field of stroke. She has a special interest in the emergency management of stroke and is passionate about finding ways to support the delivery of high quality, evidence-based care to persons with stroke, their families, and caregivers. We also have a last-minute guest speaker coming on board, and her name is Vivian Kale. Sorry if I mispronounced that. Bachelor of Science Pharmacy. Vivian is a clinical pharmacy specialist in neurology at Vancouver General Hospital and works as part of the interdisciplinary stroke team. She completed her Bachelor of Science in Pharmacy at the University of British Columbia in 2017, her hospital residency with Lower Mainland Pharmacy Services in BC in 2018, and her Doctor of Pharmacy at University of Alberta in 2019. So before I pass it along to our guest speakers today, I just want to remind you, if you have questions throughout the session, we will have a short Q&A session at the end. You can just type your questions into the Q&A section of the Zoom meeting, and kindly keep your questions relevant to the topic. For your specific medical concerns, kindly reach out to your medical team. Without further ado, I'd like to introduce Alison and Vivian.
Thank you so much, Kimberly. So I'm just going to share my screen here. And all right, so you can see the screen. Thank you so much. All right, so as Kimberly said, I'm Alison, and I'm going to be starting off this presentation, and then Vivian will also be coming in a bit later to talk about medications. So we already went over the objectives, but again, by the end of the presentation, hoping that you'll better understand the terms used by medical professionals when they talk about stroke prevention and understand the lifestyle and medical risk factors that increase your risk for stroke and how to manage them, including some common medications that are prescribed after stroke. And then finally, I always aim to emphasize the ability to recognize the signs of stroke and knowing what to do if you think you or someone you know is having one. And at the end, again, we'll make sure to pass some time for your questions. Before we start, again, a disclaimer that this presentation is not medical advice. We are giving this information for educational and informational purposes only, and this shouldn't take place of any advice that is given to you by your healthcare team. And again, if you have specific questions about your health and your care, to direct those to your healthcare team. So first, a stroke is, I wanted to go over the definition and types of stroke. So a stroke is an interruption of blood flow to the brain, which deprives brain cells of oxygen, which causes the stroke. There are two types. The most common type is the ischemic strokes, which are caused by a clot or a blockage in a blood vessel in your brain. And the second type is called hemorrhagic strokes, which are the result of a blood vessel in the brain that ruptures. There's also TIAs, which stands for transient ischemic attack, or often referred to as a mini stroke. These are in the same category as ischemic strokes, in that they are caused by a blood clot or a blockage that briefly blocks blood flow, which causes the symptoms of the stroke. But these symptoms are brief and resolve within 24 hours and usually a lot shorter of a time. But these are still very important to seek care for because they can be a warning sign for a bigger stroke. This is a list of healthcare providers that may be involved in your care after a stroke or TIA. Who you see, why, and for how long is specific to your individual care. So you might not need to see all the providers on this list. After you have a stroke or a TIA, a member of your healthcare team will let you know who you might see and follow up and where and for how long. They will help you understand where you can find more information, make sure your questions are answered, and also help you access resources if you need to. So diving into the focus of this presentation, secondary stroke prevention. So I want to differentiate between primary and secondary stroke prevention first. Primary stroke prevention are the strategies used to prevent the very first stroke from happening. What we are talking about today is secondary stroke prevention, and these are the strategies that are used to prevent the recurrent or another stroke or TIA happening when someone has already had one. These strategies focus on promoting a healthy lifestyle and managing medical conditions that increase your risk for another stroke. And this is the bulk of what we're going to talk about today. Secondary stroke prevention can be addressed in a variety of settings, including your family doctor or primary care provider's office, in the emergency room or in the hospital if you get admitted for a stroke, in a neurologist's office, or in a specialized TIA clinic. And this discussion and these strategies will be discussed on a regular and ongoing basis after you've had a stroke or TIA. When we talk about risk factors, we are talking about something that increases your risk of having another stroke or TIA. And there's three types that we're going to talk about today: non-modifiable risk factors, modifiable risk factors, and medical risk factors. Non-modifiable risk factors are risk factors associated with a higher chance of having a stroke that you can't control. So the first being age. The older you are, the higher risk you are for having a stroke, and especially over 80 years old. Generally, men in most age categories have a higher risk of stroke than women, and women have an increased risk of stroke after menopause. Having a previous stroke or TIA yourself.
Sorry, Allison?
Yes.
Can I just interrupt for a moment?
Yes.
We're just getting a few comments that they want you to speak a little louder and not too fast.
Okay, sorry about that. Thank you for letting me know.
Thank you so much.
Thank you. I am known for talking a little bit fast, so thank you for pointing that out. So having a previous stroke or TIA yourself puts you at an increased risk. Family history of stroke, TIA, or heart disease, and family meaning your immediate family, so parents and siblings. South Asian or African populations are more likely to have diabetes, high blood pressure, and other risk factors at an earlier age. Indigenous peoples are more likely to have diabetes and high blood pressure. And personal circumstance refers to things like access to healthcare and healthcare services, access to healthy food, and safe drinking water. So lifestyle and stroke prevention. So modifiable risk factors are risk factors associated with stroke risk that you can manage and treat. And we're going to talk about each one of these in a little bit more detail. And I want to emphasize that there is a lot of information in this presentation. So the goal is not to leave today thinking you need to do it all. Every change will make a difference. As I said before, secondary stroke prevention is lifelong. So please don't leave today thinking that you need to tackle every single one of these things overnight. Small changes in your daily habits, things that you can sustain over time, is what is important and beneficial. Every change you can make will help decrease your risk for stroke. And then finally, every person and their health is unique. So what makes sense for you to focus on may not make sense for somebody else. So talk to your healthcare team about where it makes sense for you to focus on. So the first thing I'm going to talk about is diet. And there are lots of ways you can make changes to your diet that will be beneficial in decreasing your stroke risk. Fruits and veggies have lots of vitamins, minerals, and antioxidants. They will help decrease your cholesterol, lower your blood pressure, and help you achieve and maintain a healthy weight. When you're building your plate for your meals and snacks, half of your plate should be fruits and vegetables. And while all fruits and veggies are great, if you can, things with fruits and veggies with bright colors like orange are great, and leafy greens. Whole grains have lots of fiber, B vitamins, and protein. So examples would be whole grain bread, brown rice, oatmeal, quinoa, and a quarter of your plate should be whole grains. More plant-based protein sources. So a quarter of your plate should be protein. The focus here being on lean meat, poultry, so chicken, fish, and plant-based protein options like tofu, legumes, nuts, seeds, and things like fortified soy beverages also count as a plant-based protein source. And for dairy, it's important to look for low fat and unflavored dairy. And for salt, you should focus on having less than a teaspoon of salt per day, which is about 2,000 milligrams. A really great way to meet this goal is by focusing on choosing less processed and packaged foods. When you're looking at labels, looking at less than 200 milligrams per serving. High fiber foods, so we've already talked a lot of what would be in this category. So fruits and veggies, lentils, beans, and whole grains all are very high in fiber and are good. Healthy fats, you're focusing on the unsaturated fats, which help decrease your cholesterol. And we'll talk about cholesterol a little bit later. The unsaturated fats are things like olive oil, peanut oil, fish, nuts, legumes, and seeds. For sugar, a great way to decrease your consumption of sugar is increasing your water intake. So not reaching for sugary drinks and canned beverages. And when you're getting fruit that's canned or frozen, looking for fruit that's in water. So not added sweetness with being in juice or anything like that. And in general, it's best to consume food in its natural form. So when food is processed, you lose a lot of the vitamins and minerals and all the fiber that we've just established. That's really important. So limiting things like white bread, white rice, chips, cookies, fast food, things like that. So with all of that information and all of the things we've talked about that are important in a healthy diet, how can you achieve this? So again, this isn't a list that you need to tackle every point right away. You can maybe just start with one item and work your way up in a way that makes sense for you and your unique needs. So one strategy is carrying a water bottle. It can be helpful, be a helpful cue to, in general, increase your water intake, but also help you reach for water more than sugary beverages. Making your meals at home can be helpful when you're trying to eat out less or eat less processed foods. And a great way to do this is by meal planning and preparing your food ahead of time. So when you're hungry and need to reach for a snack, you have lots of healthy options to reach for that are quick and easy to grab. And we talked about trying to add more plant-based protein sources on the last slide. So again, just trying to change this up. This doesn't mean you need to swap everything for a plant-based protein source. So even just one night a week, trying something like a bean chili instead of putting ground beef in your chili is great. Or adding in fish if you primarily eat red meat. When we talk about diets that are good for stroke prevention, two that are commonly referred to are the Mediterranean and the DASH diet. So they're pretty similar. The Mediterranean diet, both of these you can Google pretty easily, but they have an emphasis on fruit, veggies, whole grains, low-fat dairy, fish, legumes, and nuts, and limiting sugars and red meat. So that's the Mediterranean diet. And the DASH diet, the Heart and Stroke Foundation actually has a lot of information on their webpage about this diet. But it stands for the Dietary Approaches to Stopping Hypertension. And we'll talk about hypertension a little bit later as a risk factor for stroke. But it was based on a study where people were given this particular diet, which again focused on things like fruit, veggies, whole grains, and people in the study were found to have a lower blood pressure and cholesterol within 2 weeks of being on this diet. So if you're looking for particular diets to follow, those would be two great ones to look up in a little bit more detail. Another great strategy is eating at regular intervals. So 3 meals a day with snacks in between. And then portion sizes, listening to your body and being mindful of portions. And often that comes into play when you're eating out and the portions can be larger. And then like I said, there was a lot of information just in the diet and healthy eating section alone. So talk to your doctor about specific areas that are important for you to focus on. One person might need to focus more on fruits and veggies, while another might need to focus more on salt reduction. So talk to your healthcare team about what makes sense for you. And then if you find yourself needing a little bit more support, a dietitian would be a great person to reach out to and incorporate into your care. And then recipes, the Heart and Stroke Foundation, has a lot of recipes on their site as well that you can look at. Moving into exercise. So there is something everyone can do to be active. You can do exercises from your bed or a chair. You can do exercises at home, outside, in group classes. There are a lot of options for all levels of abilities. It is important to talk to your healthcare team about ways you can be active while taking into consideration your own health and abilities. For example, if a stroke survivor has a weak arm or leg, there is still a lot of great options and ways for them to be active. It will just be important to take into consideration what activities might be best for them and possibly incorporating the guidance from another professional like a physiotherapist. It is important to try and be active every day. This doesn't mean you need to take off after this presentation today and go for a jog. You should start small and work your way up. So even starting with 10 minutes a day of some light movement in a way that's safe and appropriate for you, and working your way up from there. The ultimate goal is being active 4 to 7 days per week for 150 minutes per week, and in episodes of 10 minutes or more. So exercise periods of 10 minutes or more. So while reducing your weight isn't directly associated with reducing your risk of having another stroke, being overweight can lead to diabetes, high blood pressure, and high cholesterol. And all of these things do increase the risk for another stroke. So again, even small changes, small weight loss can make a difference in reducing your risk. So talk to your healthcare team about the right weight for you and the best strategies to achieve and maintain that weight. So smoking cigarettes increases your risk for all types of stroke. Quitting is one of the best things you can do to reduce your risk of having another stroke or TIA, also as well as heart disease. Smoking, vaping, and inhaling secondhand smoke all put you at an increased risk of stroke. And what's great about when you talk about quitting is that you benefit from quitting smoking within hours of your last cigarette. So on the Heart and Stroke Foundation website, it says that within 20 minutes of having your last cigarette, your heart rate and blood pressure drops. And we know that blood pressure increases your risk for stroke. So within 20 minutes, you're already reducing your risk for stroke. And studies have shown that the increased risk that smokers have for stroke starts to decline after you quit. And within about 5 years, it's equal to the risk of a non-smoker. So really, you start seeing benefits almost right away within your last cigarette, and then it just keeps getting better as time goes on. And there's many resources out there to help support you quitting. There's programs, books. I've listed the Smokers Helpline down there. And there's also medications to help you quit. So talk to your doctor about what strategies might be best to help facilitate you quitting. And then also seeking support from family, friends, and caregivers. Alcohol and drugs. So excess alcohol consumption and binge drinking do increase your risk for stroke and high blood pressure. So talk to your healthcare team and your pharmacist about your alcohol intake, because alcohol also can affect certain medications you're on. So it's important to talk to your healthcare team about your alcohol intake and how that maybe needs to be looked at. The 2018 guidelines for low risk drinking in Canada, for women, that's 10 drinks per week and no more than 2 per day. Men, that's 15 drinks per week and no more than 3 per day. And in addition, the recreational drugs do increase your risk for stroke as well. So talk to your healthcare team about both of these areas. Stress can increase your blood pressure and your cholesterol, both of which can increase your risk for stroke. So everyone handles and processes stress differently. So if you think this is an area that you would benefit from support in, talk to your healthcare team about ways that you can manage your stress and supports that are available. In general, everyone can benefit from doing activities that they find relaxing. Exercise, which we had just talked about, is also can be a great stress reducer for some people. And talking to family, friends, and caregivers and leaning on them for support. Birth control and hormone replacement therapy. So high doses of estrogen can increase your risk for blood clots and high blood pressure, and both of those are risk factors for stroke. And the risk with birth control and hormone replacement therapy increases and becomes really important to think about in the presence of other risk factors. So for example, if you've already had a stroke or you're also a smoker and you're on some estrogen therapy, this is something that you should talk to your healthcare team about and talk about your specific risks. So moving on from lifestyle things that you can manage for your stroke risk, we will talk about medical risk factors and some medications now. So the medical risk factors we're going to talk about are high blood pressure, high cholesterol, diabetes, atrial fibrillation, and then Vivian is going to talk about antiplatelet medications, anticoagulants, and then some other points for medications after stroke. So high blood pressure or hypertension is the #1 risk factor for stroke. Your high blood pressure can increase your risk for stroke by weakening your blood vessels. And your healthcare team should be checking your blood pressure at least once a year. Often this is more regularly after you've had a stroke or TIA or based on your individual needs. Your healthcare team may ask you to check your blood pressure at home or at a pharmacy. And so if you do this, or if you ask them about doing this, it's important to record those readings that you're taking at home and the time that you take them. And then it's also maybe suggested that you take them at different times of day. So recording the dates and the times that you're taking your blood pressure, and then taking those readings to your healthcare and your specialist appointments can be really helpful in seeing what your blood pressure is doing at home. Ask your healthcare team about what your specific blood pressure target should be. Often this is less than 140/90. So 140, that's the top number, the systolic number, and then 90 is that bottom or diastolic number. And this target may be lower or different depending on other risk factors or other concerns. For example, if you have diabetes, this number may be a little bit lower. So talk to your healthcare team about what your blood pressure target should be. And as we talk about these medical risk factors, on the bottom of each slide, there'll be some actions you can take. And you will notice that most of these things will be repeated across the board, and they're all things that we just talked about in the lifestyle section and things that you can do. So it should be a lot of familiar things in these actions. And then I'll pass it over to Vivian, who will just talk about some medications for blood pressure management.
So there are a lot of classes of different medications that can lower blood pressure. And ultimately, the goal when we talk about stroke prevention is to meet that blood pressure target over a long period of time, lifelong, really. So when your healthcare team selects the medications, essentially what they'll try to do is to target as many other conditions that you may or may not have as possible besides decreasing blood pressure. So for example, you might recognize some of these medications if you are taking them. For ACE inhibitors, ramipril or ARBs candesartan, for example, these can also be used for heart failure or diabetes. So if you have had stroke and you have high blood pressure and you also have diabetes, then your doctor may select this drug. And then for MRAs or spironolactone, for example, these can also be used for heart failure. Beta blockers like metoprolol, for example, can be used for atrial fibrillation. So that's the idea behind choosing which kind of blood pressure medication each individual patient receives. Often multiple blood pressure medications are required for patients who are not able to meet their blood pressure target on just one medication. And so rather than increasing that single medication to the maximum dose, sometimes it works better if you have multiple different types of blood pressure medications which work at different areas in the body at smaller doses, and they work together. And that's sometimes more helpful for reaching your blood pressure target. So the particular combination depends on what the care team thinks is most beneficial for you, and also a balance of possible side effects that the individual person might be having.
All right, so moving on to high cholesterol. So if you've had a stroke or a TIA, you will likely be screened. Your cholesterol levels, or sometimes called your lipid levels, will be checked. And this is checked with a blood test, and your care team will be trying to keep your cholesterol under a certain target. Cholesterol is a form of fat in your blood, and often you will hear terms like good cholesterol or bad cholesterol. And the quote unquote bad cholesterol is the one we specifically look at, which is called your LDL, or low density lipoproteins, which at a higher level increase your risk for stroke. And the reason we care about high cholesterol is it can lead to a buildup of plaque in your blood or in your arteries. And this buildup of plaque in your arteries can make it harder for blood to flow, or even cause a blockage, which may cause a stroke. So high cholesterol will be managed with medications, diet and exercise, or both. And this is something that can either be inherited or caused by a diet too high in saturated fats, or sometimes both. And again, these actions you can take, eating a healthy diet, exercise, quitting smoking, and taking your medications as prescribed.
So the most common drug class that we use for decreasing cholesterol is a statin medication. So examples of this are atorvastatin or rosuvastatin. In terms of why we use it first for disease-modifying therapy is because it's been the most extensively studied in the literature for preventing a stroke after you've had an initial stroke or heart attack. And basically, the statin drug medication class is broken down by the liver, and then the kidneys are also involved with clearing out the byproducts of its breakdown once it's in the body. And so sometimes you might need a decreased dose if you have liver dysfunction or kidney dysfunction, and the doctors will be able to decide that based off of your liver and kidney function tests in your blood work. And then in terms of side effects for the statin medications, about 10% of patients will report muscle pain. And this is a side effect that is dose related. So if at higher doses you notice muscle pain, it may be something that can be decreased with a lower dose, and it is reversible. So if you stopped it or you decreased the medication dose, then the side effect should go away. So if you do notice this kind of muscle pain, it's often described as symmetrical on both sides of the body, and feels kind of like a muscle soreness. That's something you get after exercise. However, it doesn't go away. Like if you rested the muscle, it will still be there if you're still on the medication. So talk to your doctor if you notice the muscle pain to see if it's related to the statin. Now, sometimes people can't tolerate the cholesterol medication with just statin alone, or they can't tolerate it, or their cholesterol is still high if they're just on a single statin agent. So in these cases, we might add or switch over to alternative medications such as ezetimibe or PCSK9 inhibitors. These are newer cholesterol lowering medications, and often they come with their own side effects as well as dosing. So if that were to be an option, the care team would have to discuss with you further about these medications.
Okay, diabetes. So again, if you've had a stroke or a TIA, you will be screened for diabetes. And this is screened with a blood test again, which is typically a fasting glucose or a blood test called a hemoglobin A1C. So if you have diabetes, it will be treated with medication, changes to your diet, or possibly both. And managing your other risk factors if you have diabetes is important because diabetes can affect your blood vessels. It can weaken them, it can increase your blood pressure and increase your risk for developing plaque in your arteries. So your healthcare team will screen and monitor you for complications of diabetes, including your heart health, the health of your kidneys, your eyes, and your feet. So actions you can take are, again, you get the healthy diet, exercise, knowing and monitoring your blood sugar levels, and taking your medications as prescribed.
Just like with hypertension, diabetes medications, there are many, many drug classes for this condition. Ultimately, they target blood sugar control. And like Allison said, we're checking your A1C to see if we're still reaching that target A1C. And A1C is basically an average of your last 3 months blood sugars. So that's why it's used to look at how well your diabetes is controlled. Now, this is really for type 2 diabetes because oral medications are generally not used for type 1 diabetes. So usually we will start with oral medications such as metformin, glyphoside, glyburide, linagliptin, empagliflozin might be some medications if you're taking them that you're familiar with. And then there are also injectable medications, semaglutide or liraglutide. And then there are the injectable insulins, and the insulins are further subdivided into how long they stay in the body for. Generally speaking, the algorithm for starting medications for diabetes is to begin with an oral medication, a single agent, and see if your A1C responds to that. And if it does not, then to increase the number of oral medications. So we're trying to hit multiple different targets in the body to decrease A1C. At that point, if you're not tolerating it or your A1C is still not at target, then usually we will switch over to add on insulin or switch over to insulin entirely. If A1C is very, very high, then you might start with insulin earlier on in the treatment course. But ultimately, the goal of diabetes control not only is to prevent stroke, but as Allison said, is to preserve your function in other areas of the body as well, such as your kidney function, to prevent nerve damage in the long term, to prevent visual damage, and also to prevent heart disease. So moving on to antiplatelet medications, there are two main types of antiplatelet medications, and they're both oral medications, but they both basically decrease the ability of platelets in your blood from clotting together. The first one is aspirin, and the second one as a drug class is called P2Y12 inhibitors, but basically these are clopidogrel, or the brand name is Plavix, and sometimes you might see ticagrelor, or the brand name is Brilinta. So one or both of these may be given in combination immediately after a stroke event, and that's because the risk of stroke is higher, like a recurrent stroke after your initial event is higher in the immediate 1 to 3 weeks, sometimes 2 to 3 months, which is why sometimes the neurologist will put you on 2 aspirin and clopidogrel together. Afterwards, they will continue with just a single antiplatelet agent. And it's usually lifelong at that point to prevent future stroke. Because beyond that time frame, being on both does not further decrease your stroke risk, but does increase the bleed risk long term.
So atrial fibrillation is an irregular heart rhythm that can cause blood clots to form in your arteries, where they have the potential to travel to your brain and block blood flow, which could cause a stroke. So atrial fibrillation, or sometimes called AFib for short, is screened for with an ECG or a Holter monitor. And an ECG or an EKG is an electrocardiogram, and this records the electrical activity of your heart, and it takes about 5 minutes. So this is the test that can be done in a life labs or in the emergency department. It's that quick few minute capture of what your heart is doing in that moment in time. A Holter monitor records your heart rhythm continuously. Typically, your doctor may order this for 24 to 48 hours, and it is portable and you wear it around, and it has electrodes that attach to your chest. And this is ordered and done if your physician, for example, if your ECG came back normal and your healthcare team thought that there was a likely chance that your stroke was caused by an irregular heart rhythm like AFib, then they might order a Holter monitor to give that longer time to see if this irregular heart rhythm does come up. And it is important to know if you have atrial fibrillation because it does increase your risk for stroke by 3 to 5 times. So if your physician does find out that you have atrial fibrillation, it will be treated with medications. And the actions in addition to medications that you can do are, again, eating healthy, exercising, quit smoking, and limiting your alcohol intake.
So the goal for atrial fibrillation is, when we talk about stroke prevention, is to keep your blood thin enough to prevent blood clots from forming in the heart and then leaving the heart and going to the brain to cause a stroke. So that's why anticoagulants are used in atrial fibrillation for stroke prevention. As a drug class, it's also used in other indications for stroke prevention. However, the most common is atrial fibrillation. So there are oral anticoagulants, the older one being warfarin, which requires frequent INR or a blood test in order for the physician to watch for your dosing and to keep your INR test within a therapeutic window. So warfarin is often no longer being used for that reason. The newer oral anticoagulants are apixaban, rivaroxaban, or dabigatran, and these do not require those regular blood tests. So they're taken either once or just twice a day regularly. The side effects of blood thinners is that because your blood is thin, there are bleed risks associated with them. The more common ones are minor bleeds. So think of these being the bleeds that are nearer to your surface and therefore easier to recognize. So you might notice that you bruise a bit more easily than before. Some people complain about more frequent nosebleeds than they did before, and gum bleeding when you brush your teeth. So we recommend a softer toothbrush. However, these are the bleeds that should go away after time. So your nosebleed should not continue without stopping. Your gum bleeding will stop by itself. It's just that it will take longer for the bleeding to stop because your blood is thinner than most. And these are the side effects that, compared to having a stroke, we consider to be acceptable side effects because they're smaller bleeds. The major bleeds are more serious. These can be life-threatening. They're also rare, but they're harder to recognize because they're more internal. So if you see any signs of these major bleeds, then it's important not to continue taking your blood thinners and to go to emergency right away to get it checked out. So if there was bleeding in the brain, the symptoms of that can actually look like stroke symptoms, which Allison will talk about later for specifically what to watch for. And the important thing is, if you have these symptoms while taking a blood thinner, let's say you called 911 because you think it might be a stroke, and they tell you to take a blood thinner or take an aspirin. Because you're already taking a blood thinner, don't do anything and go straight to emergency. Don't take an extra one because it could be a bleed or it could be a clot, and we won't know until you get into the CT scan and they take a look at your brain. And then the other areas internally that can bleed are the stomach. So if there's an ulcer, then there could be blood. And by the time it makes its way out, it might not look red anymore. So if you vomited it up, then it could be a coffee ground color. And then in the stool, it could make the stool very black, kind of like tar. So those are not normal colors, even if you don't have stomach pain. Make sure you go to emergency right away to get that checked out and tell them I'm taking a blood thinner. And then the last thing is for urine, it should remain a normal yellow color. If there is blood in there, it can make it tea colored. So that's also potentially a medical emergency. So go seek emergency for that. So some other medication related information for stroke include post-stroke mood. Decreased mood does affect many stroke survivors, and in some cases may benefit from an antidepressant medication. So this should be discussed with the healthcare team. And there are many different medication classes for antidepressants, and the healthcare team should check if there are any interactions with your other medications to make sure there aren't any. Importantly, it may take 2 weeks for initial response to medication therapy if you were to start an antidepressant, and up to 4 to 6 weeks for a full response. So if you've taken a few doses and you haven't noticed any differences, that may be because there hasn't been enough time on this medication to really see a response. So it's important to wait a bit longer. And then for natural health products, there are some that have properties that can interact with medication, specifically with blood thinners, such as omega-3 fatty acids, ginger extract, or garlic extract. And then there are some natural health supplements that can increase or decrease liver or kidney function, which can also indirectly cause interactions with many other medications, such as antihypertensives for your blood pressure. So if you're thinking about starting any natural health products or continuing on natural health products, make sure you check with your pharmacist to see if there's any drug interactions before starting or continuing to take them. And lastly, because stroke prevention is a long-term, lifelong preventative method, the important thing if you were to take medication is to continue to take medications as your doctor prescribes. Generally speaking, your body can't really feel high blood pressure or high sugar levels or high cholesterol. And we monitor for those using blood tests and in high blood pressure using blood pressure readings. So in addition to that monitoring, you're also monitoring for side effects to balance the dose of the medications that you are prescribed. So help your health team by keeping track of side effects. And if you're monitoring blood pressure at home, by keeping track of what you've monitored. And then discuss any concerns or side effects with your care team before making any medication changes yourselves.
Okay, and lastly, going over recognizing stroke and TIA. So I always like to end with going over the signs of stroke. So the FAST, probably most people have heard of it. Face, you're looking for if there's a droop on the one side or the other of the mouth. A common way to do this is to ask someone to smile and see if there's a droop. So for arm strength, asking someone to raise both. If someone might have a little bit of weakness in the arm or a pretty dramatic weakness, or they can't move it at all, any of those would be considered a positive FAST sign for arm strength. For speech, looking to see if it's slurred or jumbled. So differentiating between those, slurred speech can often be compared to sounding intoxicated. So they're still saying the correct words, they're just hard to understand, versus jumbled speech, someone is not making any sense. They're saying words that don't make sense for what they're trying to say, or they may not be able to speak at all. So again, any one of those would be considered a positive sign. So if someone has any one of those, they don't need to be all, they can just have one, then it's time to call 911. And another important thing to consider is if you've had even, again, one of these, but the symptoms resolve and get better, it is still important to call 911 and seek care right away, because that could be a TIA, which, as I said earlier, could be a warning sign of a bigger stroke. So even if symptoms get better, it's still really important to get them checked out. And then while these are the most common symptoms of stroke, the other ones that are good to be aware of are any changes in your vision. So things like double vision, if you were to suddenly lose vision in even parts of your eyes, like seeing a little bit of a black space somewhere, that would count, or blurry vision. Numbness on one side of the body. If someone were to have a really hard time balancing, trouble walking, or also a sudden severe headache. Those are things that could also be signs of stroke and are important to get investigated right away. And it's always important to seek care sooner than later, as a lot of the treatments we can do for stroke are time sensitive. Just some references, and then thank you. That's the end of our presentation, and we'll open it up for questions.
Thank you, Allison and Vivian. What a great presentation. We do have quite a few questions in the question and answer. We have about 10 minutes left and we have about 10 questions. So I will get you through these questions. The first question we have is, I have heard from a neurologist that cognitive stroke deficits can improve with the use of drugs such as Ritalin or duloxamine, Cymbalta. Can you comment on this type of drug therapy? I guess that would be a question for Vivian.
There hasn't been strong evidence to support either Ritalin, which is methylphenidate, or duloxetine specifically for cognitive deficits in stroke, as at least not in the guidelines. And the evidence has been, like when they did literature studies for these drugs, it was more in the sense of for rehabilitation and neurocognitive benefits, and that hasn't been conclusive. So Ritalin as a drug class has not really had any benefit in stroke, in the post-stroke recovery. Duloxetine is an antidepressant. Duloxetine, sorry, is an antidepressant. So sometimes we will use them if patients have antidepressive needs.
All right. Well, thank you very much. I see another question here. I see lots of commercials for Balance of Nature fruit and vegetable supplement tablets. Are they good or bad?
Generally, the supplements probably aren't as good as the real fruit and vegetable if you can take those without any issue. Because the benefit you get from real fruit and real vegetable, often you absorb it better.
Hey, thank you. What about the cost of groceries when looking at your diet? I know we talked about diet today and that question came up.
So that's a really good point. And like I said, for the non-modifiable risk factors, for things that you can't change, and one of those being personal circumstance. So absolutely not everyone can afford a diet that's rich in fresh fruits and veggies. So for example, a great way, a less costly alternative to incorporating fruits and veggies is to get frozen. So the frozen is often a little bit cheaper and a little bit more widely accessible. The one important thing, as I mentioned, when looking at frozen or canned fruits and veggies is just being mindful of added sugar, and that's usually with fruit. And a great way to easily see is often fruit will say it's either canned or stored in juice or in water. So choosing options for in water.
Okay, thank you. Good suggestions. We talked about exercise as well in this presentation. A question came about, are stairs considered exercise?
Absolutely. So the goal is to be getting, the ultimate goal is to do exercise that gets your heart rate up. But like I said, starting small. So doing stairs is a great way to get some exercise for some people. So if that's your starting point, that's fantastic. Even, you know, if that you could park further away in the parking lot from the grocery store entrance, and that's a great starting point too. So I really don't want people to feel like they're leaving this presentation with this pressure to do really big changes and really big things. So if that's your starting point, absolutely, that's great. And then when you start to feel that stairs is quote unquote easy for you, then maybe trying to find other ways to increase your exercise.
Well, thank you. And I know you talked about, Allison, monitoring your blood pressure. There's just somebody had said that they thought about buying a blood pressure machine from their drugstore instead of relying on the visit to the walk-in office. I wonder if you could comment on that.
Yeah, so that's great. A lot of people do have home blood pressure monitors. And that's a great way to, some people's blood pressure naturally rises when they go to their family doctor or care team anyway. So it's a great way to see what your blood pressure is doing at home. The one caveat here is sometimes home blood pressure machines just need to be calibrated, or what that means is they're giving a reading that's generally not correct. So if you have noticeably different blood pressure readings at home than what you're getting in the office, then it's a good idea to just make sure your blood pressure is calibrated or reading correctly. And sometimes certain pharmacies can help you with this.
Thank you. Question about medication here. Are cramps considered muscle pains that could be caused by using rosuvastatin?
Yeah, the muscle pains from the statin class are often referred to as cramps. They might feel like a cramp from after heavy exercise. But with those cramps that tend to go away with rest from a very hard workout, for example, they don't tend to go away with a statin medication. They are constant. And I tend to describe them as large muscle groups. So let's say your thighs, and they tend to be symmetrical. So if it's on your left thigh, then the muscle pain should be on your right thigh as well, or your right calf and your left calf. And not smaller muscles like your finger muscles, for example. But they might feel like a cramp.
Well, thank you. Another question about 81 milligram aspirin. They were informed to stay away from 81 milligram aspirin. So I wonder if you could comment on that, or?
It really depends on your specific scenario. If you have an allergy to aspirin, then we might stay away from it, or if you're taking a blood thinner, like an anticoagulant, and you don't need to be on the aspirin, that would be a different scenario. So check with your doctor.
Absolutely. Allison, we have a question here about fast. When I had my stroke, I didn't experience fast. So I wonder if you could comment on that.
And that's why I mentioned those other stroke symptoms as well. So fast is the most common stroke symptoms, but they can absolutely be other things, like things with your vision or a headache or trouble balancing. So without knowing what symptoms you were having, it's really hard for me to comment. But generally speaking, it's always better to err on the side of caution. And if you think you're having a stroke or someone else is having a stroke, it's always much better to call 911, get to the hospital right away, and let the experts figure it out. Because as I mentioned, so many treatments are time dependent. So it's always better to err on the side of caution and never feel silly or for coming in and getting that checked. No one should ever make you feel silly for wanting to know.
Well, thank you. We have I think a medication question here, and quite a few extra questions that came in. We'll get to the ones that we can, but we do only have 5 minutes left, so we'll go with that. I'm on, and just to mention, you will get a copy of the presentation after for attending, and the recording will be available as well. Here's the question. I'm on rivaroxaban for AFib. I'm so sorry for butchering that. What about the platelet drugs is the question.
Rivaroxaban is a blood thinner anticoagulant, and it should be, or is a correct medication treatment for atrial fibrillation. There are very few circumstances where you would need to be both on rivaroxaban and an antiplatelet drug on top of that. The most common of which is you've recently had a stent. So that really depends on what your care team thinks is necessary. But for most patients who are just have atrial fibrillation, they don't need to be on an antiplatelet medication on top of rivaroxaban.
Thank you. A question about blood pressure. 140/90 as a blood pressure has been mentioned. Does that change with age, or is that the target for everyone with diabetes and high blood pressure?
For diabetes, oh, sorry, go ahead.
No, we could both answer this, but I'm sure our answer will be the same in that 140/90 is the general consensus of where your blood pressure should stay under. If you have diabetes, that might be slightly lower, 130 as the top number over 80. But this is why it's really good to talk to your healthcare provider about your goal, because various risk factors and circumstances might affect what your specific target is. I don't know if you have anything to add, Vivian.
No, yeah, exactly.
Thank you. And I think we have room for one more question here. If you didn't have an opportunity to ask your question, please reach out to me and I will see if I can get it over to Allison and Vivian. I'm sorry we didn't have enough time to get through every question today. But the last question that we have today is, can you talk about saturated versus unsaturated? I'm a cheese lover, they say.
Sorry. My mute's being funny. You can hear me now? Okay. So saturated versus unsaturated. I mean, it's absolutely when talking about diet and changes in general, do things that you can sustain. So it doesn't necessarily mean you need to, take all cheese out of your diet. Look for low fat cheeses. So when you're thinking about cheese, that's more in the dairy category, and looking at ways to get low fat cheeses and just consuming in moderation. And then if there are things that you'd really like to incorporate in your diet, or you have specific diet questions, a dietitian can be really helpful. Or again, looking at the Heart and Stroke website for recipes that maybe some that can include cheese in a way that you can still reduce your risk factors while still enjoying cheese occasionally.
Thank you very much to Allison and Vivian. We did get a comment coming in that I just want to share with you before we go. Just that it was a fantastic overview of modifiable stroke risks and also about the commonly used medications post-stroke and their purpose. Thank you so very much to Allison and Vivian. And before we go, I would like to share my screen and share with you. Also, just want to say thank you very much for attending today's session. If you would like further information on your current situation, please reach out to your after-stroke coordinator. And if you have any questions, you can reach out to me, or you can reach out to the information navigator or our stroke information line. Just say thank you very much for attending our session today. And thank you, Allison and Vivian, for your time and your expertise.
Thank you.
Thanks.
Thanks. Everybody have yourselves a great day. Thank you very much. We'll end the meeting now. Thank you.